Welcome to this explainer on vestibular neuritis. This is the first installment of our clinical series, Vestibular Medicine for Vestibular Physicians. Today, we're going to be unpacking the epidemiology of this incredibly heavy-hitting condition to give you a really confident visual first grasp of the modern clinical landscape.
So, let's kick things off with a massive real-world reality check. Vestibular neuritis is the second most common peripheral vestibular disorder out there, sitting right between BPPV and Meniere's disease. But more importantly, it is the absolute most frequent cause of acute, prolonged vertigo presenting to emergency departments worldwide. It's a huge burden.
Now, as you well know, the absolute clinical urgency in these acute ED presentations isn't actually the peripheral deafferentiation itself. The condition is benign and self-limited. The real issue is the high-stakes, keep-you-up-at-night requirement to reliably exclude a posterior circulation stroke. Because of the sheer volume of these cases, misattributing a stroke to a simple inner ear virus is a constant looming operational hazard.
Take a look at this recent paradigm shift in our nomenclature. In 2022, the Barany Society officially proposed the term Acute Unilateral Vestibulopathy, or AUVP. Why the change? Well, because the true underlying etiology simply cannot be confirmed in the vast majority of our patients. This syndrome-based term is just far less mechanistically presumptuous. That being said, vestibular neuritis definitely remains our daily clinical shorthand, so as vestibular physicians, we need to be totally fluent in bridging both terms.
Right, so when you're face-to-face with that abrupt onset of severe rotatory vertigo, your bedside assessment sequence is your ultimate anchor. It's the systematic integration of the clinical history and bedside tests, like your HINTS battery, that actually confirms the peripheral dysfunction while safely ruling out any central nervous system signs.
Let's talk numbers and look at the global annual incidence. Population-based studies show a really massive spectrum, anywhere from 3.5 to 15.5 cases per 100,000 persons. But notice the disparity here. Japan reports a very conservative 3.5, but look at Italy. When comprehensive, VHIT-based diagnostic protocols are actively applied in multi-center data, they are approaching 20 per 100,000. The implication is pretty clear. The true incidence likely sits at the very upper end of this spectrum in high ascertainment settings.
This table is a fantastic quick reference for the core epidemiology. Beyond that, annual incidence, AUVP consistently commands a massive 3 to 10% of all presentations to tertiary dizziness clinics. And the peak strike zone? It predominantly hits individuals right in their 4th to 6th decades of life, with an absolute peak incidence clustering in the 50s.
Demographically speaking, the baseline split is roughly equal across the wider population. Well, mostly. If you look closely at the most rigorous datasets, they actually reveal a mild female predominance, capturing somewhere around 55 to 60% of presentations.
But actually, let's nuance that view a bit. A really comprehensive Korean longitudinal analysis spanning from 2007 to 2022 revealed a higher male incidence specifically in patients over the age of 50. So when you're counseling older male patients presenting with acute dizziness, recognizing this specific age-sex interaction can sharply elevate your diagnostic suspicion. It's definitely something you want in your back pocket.
On the complete flip side, pediatric cases are exceedingly rare, making up just 3 to 5% of acute presentations. But here is the alarming part. These cases are routinely, almost reflexively, misattributed to anxiety or vestibular migraine. If a child presents with an acute vestibular syndrome, formal vestibular testing, especially the V-height and audiometry, aren't just recommended, they are literally non-negotiable.
Let's walk through the typical clinical timeline. Roughly 40 to 50% of adult cases kick off with an antecedent viral upper respiratory prodrome. Then, boom, it abruptly cascades into peak, incapacitating symptoms. We're talking spontaneous nystagmus and severe postural instability. Eventually, they slowly transition into the central compensation phase, where the brain tries to adapt to that sudden sensory asymmetry.
Now here's an absolutely crucial point. Time alone does not heal all wounds here. Recovery is not guaranteed just by waiting it out. The completeness and speed of that central compensation heavily depend on the severity of the initial deficit, which we obviously quantify through chloric canal paresis and VHIT gain reduction. But equally critical, the patient's direct access to specialist-coordinated vestibular rehabilitation.
So, bringing this all together, AUVP is mechanistically well-characterized, precisely diagnosable, and highly management-sensitive.
Because recovery relies so heavily on targeted rehabilitation and accurate subtype identification, your specific expertise as a vestibular physician fundamentally and measurably changes the patient's long-term functional outcome.
Which leaves us with a really critical question to reflect on. If we possess precise diagnostic tools, and we know for a fact that early specialist intervention and rehab dictate the compensation trajectory, are we actually doing enough to intercept these patients right at the emergency room door? Bridging that gap is exactly how we prevent maladaptive chronicity from setting in.
Thanks for joining me for this explainer on vestibular neuritis. Keep that final question in mind and stay tuned for our next module, where we'll dive deep into the pathophysiology and etiological mechanisms. We're going to keep advancing your clinical command of vestibular medicine. See you then.